Hi, good afternoon, everyone. Welcome to the SAS Afternoon Forum. Today, we are going to discuss Healthier Singapore, mainly focusing on the capitation models. The forum will be 1.5 hours, split into two sections. First half will be introduction and some background of the topic, and second half will consist of the panel discussion, followed by the Q&A. A brief introduction of our speakers and panelists today. So we have Tien Yung. He's the Chief Commercial Officer at Healthway Medical Corporation Limited. He has experience across employee benefits and healthcare at FWD and Parkway. We have Lydia with us. She's a qualified health actuary with experience in the health insurance and wellness industry. She's skilled in health analytics, product development, pricing, and strategic health risk management consulting. In her previous role, Lydia was working with W2W, and recently she has joined Amplified Health. Then we have on our panel Dr. Joanne Yung today. She is CEO of Research for Impact in Singapore. She's also visiting scholar and research fellow at the University of Southern California, the Center for Behavioral and Implementation Science at NUS Medicine, and the Sim Ki Boon Institute for Financial Economics at SMU. Welcome on board.
Thank you.
And we have Tim Goodhue. Tim is Deloitte Australia's government and public sector actuarial lead partner. He has international experience in the US, MENA, and across Oceania in healthcare, funding, analytics, and value-based care. Tim is passionate about helping health, government, and public sector clients understand and harness the power of data to drive evidence-based policy and improve social outcomes. Hi, Tim. Welcome to the session.
Great to be with you all. Hi, everyone.
With this, we can start. So we move to Tien Yung.
Hi, everyone. Hope you all can hear us fine. Today is a hybrid event. We are both physically here as well as you're joining virtually. Before we start, I just want to provide a little bit of a disclaimer. We have taken a lot of effort in compiling this presentation together. I'm presenting on behalf of the working group as a whole. But at the same time, we are presenting as individual members of the profession and not representing our employers or the Actuarial Society's formal response. This Healthier SG strategy is somewhat new and the details are a little bit skimpy. So we are working off only publicly available information. Right. So this being an actuarial forum, there'll definitely be data tables. For all the other tables, at the risk of being repetitive, 2020, 2021 because COVID. Okay. Our objectives here is to introduce attendees that are not health actuaries about capitation models, the hows and the whys. And more importantly, we also want to demonstrate how health actuaries add value to the design of capitation models. So the agenda for the first 40 minutes will be split into two. The first part I'll be taking, we're discussing about Healthier SG and the Singapore context. Before I pass the time over to Lydia, who will be talking about capitation models. So what is Healthier SG? Healthier SG is a major initiative to focus on preventive care. It was just announced in March 2022. And there are 5 key trusts, starting with the family physicians, using the private GPs to deliver more care. Exactly what care are we talking about? The idea then is to have the family physicians lead care plans or what they call care pathways, and also have screening and preventive health. This context is important as the disease burden shifts towards more chronic conditions or lifestyle diseases. So in the context of chronic conditions, community partnerships matter because it is also about eating healthier, living healthier, exercising more. So there are more comprehensive thinking beyond just seeing a doctor. Now we reach to the core of this discussion we're having today. First part is the National Healthier SG enrollment, and what that means is that each and every person will register with a family GP as the first line of care. For this year, they are targeting the above 40s first, and there are other examples in other countries, things like patient-centered homes or the primary care physicians or preferred care panels. With this whole thing, there's also other things that we need to do around manpower, especially allied health, non-doctors, having more nurse practitioners, having more allied health professionals. And the financing model is also changing, and the IT systems will also change significantly in order to tie up what are largely private GPs together with the hospital or regional healthcare systems. So today's topic is mainly covering these last 2 points, where the funding model for the regional health systems, which is the public hospitals, is changing from a workload-based or diagnosis-related group, DRG-based, to a capitation model. So why this change is necessary in the first place, right? Starting with supply, the government from 2010 to 2020 has spent quite a lot on increasing supply, right? If you're looking at acute hospital beds, it's growing at 3%, 3.4% per year, in total 40% increase. And at the same time, they are recognizing, and they have recognized in the past, that continued growing hospital beds to meet demand is not sustainable. And they have been pushing very hard on community hospital beds, or what they call step-down care or subacute care. At the same time, the private GP clinics have been keeping pace. Single GP providers or partnerships, they have been setting up at a rate of about 3.6% per year. So looking at the demand side, right, here there is quite a fair bit of numbers, but the first 2 lines on the top are basically outpatient care. The red line is the polyclinic utilization. The yellow line is specialist outpatient. Then subsequently is the inpatient admissions as well as day surgery admissions. In aggregate, you can see that it is 3+ percentage points growth. So it is only slightly less than capacity increases, but this is actually a result of the pandemic. Pre-pandemic, the situation is actually worse. Demand actually has increased by 4+%, which is outstripping capacity. So in the minister's speech, they are highlighting 2 things around healthcare demand. One is obviously in relation to demographics. As the population age, more healthcare is needed. But the second thing is actually around ill health. If the people are less healthy, they consume more than necessary. So starting on the old age discussion, right? You can see here is a chart breaking the resident population into 3. Residents meaning citizens as well as permanent residents. And starting from the lowest green one, the youngest 0 to 14 years old, they've actually dropped by 1% per year, right? And in the largest group of 15 to 64 years old, you can actually see growth largely being flat, right? But at the same time, you look at the 65 and over, you can see growth at 6% per year. That in itself is a problem, but it's actually compounded by the fact that the percentage of those 65 years and older has grown from 9% all the way up to 16 percentage points, right? if you consider from the government's perspective, taxpayers are effectively the under 64 years old, and there is a challenge that they are facing. Looking on the demand side again, taking only one, which is acute hospital admission by age band as a proxy, you can see that the pink groups, right? 16% of population above 65 years old is consuming 40 percentage points of hospital admissions. And it is actually, pre-pandemic, is actually growing faster than the population itself, right? 2010 to 2019, 65 years and over is growing at 6% per year. But in terms of hospital admissions, 2010 to 2019 is growing at 7% per year. Looking at the average admissions per year in aggregate across the whole resident population, you actually see that in 2010, it used to be 9.6% incidence per year. That means roughly 10% of population get hospitalized in any given year, up to a peak of 13.6% in 2019, before dropping back to 11.5% in 2021. How much did all this cost, right? So over here, you can see the green lines are basically the total government expenditure, operating expenditure, right? Not really relevant for discussion per se in relation to how much money that they are spending, but when you compare the health expenditures, whether total or operating, at 15+ percentage points per year, it is a concern because it is double what the government is spending. And in the Singapore government context, generally they're spending within what they're earning as well. So health growing at a rate that's double total government expenditure is a problem. So looking on the individual side, right, private consumption expenditure for health is growing at about 5.9% per year, but disposable income is growing at 5% per year. So there is also a bit of a problem. In a Singapore context, outside of the government, who are the other large payers of healthcare, right? The largest private payer of healthcare is actually household out of pocket, right? So this initiative around making people live healthier also benefits the regular med industry. The next group is what used to be voluntary healthcare schemes by corporations. That means companies paying for employee benefits or paying for healthcare for their employees. And the compulsory contributory schemes in a Singapore context is largely MediShield Life as well as Integrated Shield. And you can see these two lines inverting, basically because of the expansion of MediShield Life in 2015-2016. And the last one is just other insurances that households are paying. Okay, so what have been the past initiatives by the Ministry of Health? Starting from 2012, there was a master plan by the former minister to enhance accessibility, quality, and affordability of healthcare. Right? The challenge obviously is to hit all three. Hit any two is very easy, but to hit all three, that is a challenge. And in 2014, they have started subsidizing more on outpatient care instead of the previous thinking or paradigm around inpatient care. In 2016, they introduced the 3 Beyonds, right? Beyond hospital to community, where they want care closer to home. Beyond quality to value, where just looking at the in a healthcare context, quality and value is in relation to outcome versus the money that you spend, right? So the best possible care, regardless of cost, is not in this context not very good care. So beyond healthcare to health. And what this means is instead of taking care of people when they fall sick, there are investments into helping Singaporeans stay healthy in the first place. In 2018, recognizing the challenge in relation to manpower, they have been trying to improve on healthcare productivity and putting millions into the fund. Again, this community health assist scheme continued to be larger in 2019, and it enhanced the subsidies of the private GPs. And 2021, aging in place was a big theme. So when you look at these things that they've been doing in the past, vis-a-vis the recent announcement of Healthier SG, you actually see that it is a repackaging or combination of past efforts or past trials, past experiments they've done. The big change this year would be the changing of the funding model from a DRG-based funding to capitation instead. Then finally, there is an alignment of the financial incentives of the medical provider vis-a-vis the stated goals. So as a health system, Singapore does have high performance versus what the amount of money that they're spending, right? So the life expectancy is high and is improving, whether you're looking at life expectancy above or health adjusted life expectancy, right? Both numbers have grown. But chronic lifestyle diseases, non-communicable diseases still remain a challenge, right? The joke among the medical fraternity is diabetes, hypertension, hyperlipidemia, DHL. You have all three, you go faster. Outside of diabetes, of which there is a reduction in both high cholesterol and high blood pressure, there have been a massive increase. So in the context of capitation, the financial measurements are insufficient. Right? You do actually need to measure non-financial stuff around, for example, accessibility. Right? You can definitely save money if you don't let anybody see the doctor, right? But in the Singapore context, they are declaring publicly, how long does it take, to see a GP at a polyclinic, right? And in the more demanded services, like especially the specialist outpatient, the numbers are, reasonable at 80+% of people having to wait less than 2 months to see a specialist. So on the bed occupancy rate as well, it is pre-pandemic 80+%, and it hit as high as 86% before dropping. So obviously, accessibility is only one part, right? Quality, the only publicly available quality measurement we have is hospital readmission rates. And how this matters is if people are not, in that sense, taken care of properly and discharged too early, the readmission rate will be high. But in the Singapore context, the numbers seem reasonable. We do know that the various hospitals do have other quality measurements around mortality rates, complication rates, of various surgeries and stuff like that. But at the same time, these are quite loaded numbers if full context is not given. Therefore, these numbers are not generally publicly available. So tracking health outcomes and other quality measurement definitely is critical in the context of capitation, right? So care rationing may emerge as an unintended consequence if the financial as well as the health outcomes are not measured and prioritized at the same time.
So moving to my part of the presentation, In this part, I will be discussing some of the basics around capitation and health funding models for those non-health actuaries, to just give a context to the discussion that we'll have with the panelists a bit later. Of course, in practice, these can get quite complicated, so the discussion will not be covering all aspects, but rather just give some fundamentals to highlight some of the key considerations when you're comparing different funding models. To best explain capitation, I want to compare it first to the most intuitive health funding model, which is fee-for-service. In a fee-for-service model, as depicted on the left of the slide, the funder of health services pays per service provided. So the overall cost, if you sum all of those dollar signs next to the services, will depend on the number of services provided to the patient, as well as the price for each of these services. Of course, in healthcare, the patients or beneficiaries of these services at the top are all at a knowledge deficit, and it is generally the treating physician at the bottom that has the most say in which services are recommended, and hence what the end cost may be. Changing this to a capitation model on the right means that the funder, whether this is an insurer, a government, or whoever pays the bill at the end of the day, pays a predetermined amount per beneficiary under management. So the population here could be the general public, it could be employees of a certain employer group or policyholders for the insurer. And the receiver of these funds could be the providers themselves or a health maintenance organization who then pays the providers on a fee-for-service basis. But the big difference in this case is that the receiver of the capitation fee now has a predetermined amount of funds which can be used to cover the services, and therefore has some incentive in controlling the cost of the treatment that will be recommended. Now, these are not the only type of reimbursement models for health. There are many different types of providers and many different types of services. So typically in a health system, you would have a number of different types of reimbursement. So for the members of the audience who might not have experience in assessing different funding models, I would like to talk through a couple of these models to highlight through a practical example some of the issues that tend to arise when changing funding models. In the comparison, I will keep fee-for-service on the left and capitation on the right, but also add two more: paying per day in hospital and paying per event. In my comparison, then, I'm also going to discuss three different viewpoints: the funder, the provider, and the beneficiary or the patient. So let's start with the funder in a fee-for-service model. And as an example, let's say I need to go to hospital for a hip replacement. Under a fee-for-service model, the total cost, as mentioned, will depend on all these services, which is quite significant. It includes the hospital room and board, surgeon's fees, anaesthetist fees, the cost of the actual implant, not to mention all the things such as medication, tests, radiology, physiotherapy, and so forth. The funder will only receive the final bill for all of these services after discharge, and therefore does not know the exact cost ahead of time. Uncertainty in terms of budgeting for this cost is therefore very high. Now, the many different providers involved in this treatment will receive payment for all of their services, and so even if there's a complication during my procedure and I end up staying in hospital much longer than expected, there's no risk from the provider side that the funds received will not cover the costs of providing these services that are necessary. And so from the beneficiary's point of view, the treating physician does not need to hold back in terms of the number of tests or services they recommend. So actually the funder may impose some benefit limits in terms of what they're willing to pay for, just to limit this cost a little bit at least. And so maybe there will be some out-of-pocket payments for me as the beneficiary to cover as well. Note also that too many services is not necessarily going to guarantee better health outcomes for me. Taking too many different medications or potentially harmful tests can also be detrimental to my health. So in health, more doesn't always equal better. Moving then to per day. And practically, this would typically only consider the hospital portion of the cost, with the other physicians still receiving a fee for service. But now, at least for the funder, they're paying a predetermined amount per day to the hospital. So it removes some uncertainty in terms of what that cost will be. However, when considering the overall amount they will be owing the hospital, they still do not know how many days am I going to stay for and what type of admission will they be paying for. From the provider's view, the hospitals now have, well, the hospital provider now have a fixed daily rate. And so there's some responsibility for the hospital to at least manage the efficiency in the daily basis. If I stay in hospital longer than expected, they are still covered for these additional days. But maybe the funder wants to reduce the payment at a later date so the hospital do not keep the patients for too long. Also, the daily cost of admitting me for a hip replacement will be very different to the cost of admitting me for sinusitis, for example, where there's no theatre time or ICU stays needed. So the daily fee would typically also take account of the type admission to take account of these different services that the provider actually needs to give me. As a patient, I will probably get the service that I need from the hospital, but manage maybe a bit more efficiently, and maybe the number of days might depend on how these services are remunerated. Moving then quickly to the event cost. In this case, still being paid to the hospital, but this time my hip replacement, it's a predetermined fee, irrelevant of how long I stay in hospital. This obviously removes some of this uncertainty in terms of length of stay for the funder, although there are different severities and types of admissions. And of course, there is also the overall admissions where the funder doesn't know how many people will get admitted at the end of the day. To compensate providers then for the fact that some cases and some patients may be more complicated than others, the events are typically funded using risk-based payments, such as DRGs, which not only takes into account the type of admission, but also the risk of me as a patient in establishing what an appropriate fee might be for an admission. Some payment models might even be global fees, so that other provider types, such as the physicians and surgeons, or even the implant might be included in this predetermined amount. So there's even an additional incentive then for all of those providers to work together to manage the cost of the overall hip replacement. Still, pay per event, in the event, if it still triggers the payment. So there's very little incentive for providers to prevent my admission, and perhaps even an incentive to admit just in case, even if not strictly necessary. Then you get to capitation, where for the first time now, the cost of my hip replacement is not a factor anymore to the funder, but rather only the size and the risk of the population that they need to pay for. And therefore, much of the uncertainty in terms of event risk has been removed for the funder. Best case scenario from the provider's perspective is that I don't need a hip replacement. Maybe there's a less invasive procedure that will fix things for me. Maybe I should rather be attributed to a different provider group for capitation purposes. So in this case, the provider for the first time is exposed to the risk that there may be many more admissions required than budgeted for, and also that the cost of these admissions might be higher than expected. Funders also do need to consider how they allocate the capitation fee per beneficiary that will enable these providers to cover their cost. Since providers offer different types of services, and they will also see different segments of the population, this needs to be taken into account. To do this, capitation rates might be risk-based, taking into account age, for example, of the beneficiary, and the services under the capitation might also be limited, such like including only less volatile types of services, such as GP services, for example. Since providers are now incentivized to prevent high-cost events, more emphasis can be placed on preventative care. As T.Y. also mentioned with the Healthier SG initiative, it's a shift from hospital-based care to preventative care that's really the key item in capitation. As a beneficiary, I might not need to go through extra steps to get to that mission, such as first getting referred to a GP and then seen by a specialist. So it adds a bit more rules to me, perhaps. And in the worst case scenario, perhaps the provider is not able to manage its finances and risk very well, and so runs out of funds to provide adequate services that I actually need. So let's summarize just some of the key things we have been talking through because these are the things that's going to come up in the panel discussion later. Firstly, most importantly, it is the quality of care that will be received by the patients. Are providers suitably and fairly remunerated to provide the right level of care to the right patients? Secondly, is the risk faced by the providers. Is this transfer of risk fair? Are they able to manage this risk adequately? And do the level of payments adequately account for the type of patients they will be seeing and the type of treatments or services that is included under the payment model? And how do the incentives align for all the providers that are treating the same patient? And lastly, for the funder side, what are the mechanisms in place to help manage cost and keep the overall cost of health services affordable, while still making sure that the services being paid for is good quality health services that will improve the health of the beneficiary that they are funding? So looking at all these payment methods, the glaring difference in capitation, as mentioned, is the preventative care. So let's just quickly look at preventative care and cost management. Now, it's a complete topic by itself, but just to again highlight some key aspects, just to again highlight the key aspects of preventative care. As a hospital, once the patient gets to you, it is too late to prevent this admission from happening. So managing health to prevent the hospitalization is typically the role of the primary or secondary care physician. As shown by TY earlier, also chronic conditions is a key risk in driving admission costs. So managing chronic disease is important if you want to manage the admission rate into hospital. How you might go about doing this is by first segmenting the population into different risk groups. The smallest proportion of population at the top would typically account for the highest costs. These are the high-risk individuals who have multiple comorbidities and whose health is not well managed. These individuals would need individualized health management of their specific conditions by their GPs or specialists that treat them, and may also need help coordinating all of these treatments to make sure that these are aligned to actually keep the patient healthy. Another group is the second one, the emerging risk group, might be individuals who have one or two conditions, but not immediately at risk of complications. And I should add also that this is a very simplified example in disease risk management. You might actually have, or you will actually have many more groups. But the emerging risk group as individuals, they might need education and support, for example, from their GPs in how to appropriately manage their condition, how to take the medication, how to use the asthma pump, all of those types of things. Make sure that they actually do know how to treat their condition. And lastly, the majority of the population would be the healthy population without conditions. So in this case, the individuals responsible for managing the health of the individuals need to ensure that there are no emerging conditions that's not known of. So it needs to be picked up promptly through preventative testing. And also, best case scenario is also to make sure that these individuals exercise and they don't develop the conditions. Is there a problem with the sound?
Yeah. I think the video was frozen.
Oh, what happened? We know when we lost the sound?
No, yeah, we're back.
Okay.
Do you need to repeat anything, or
Yeah, where are we?
where did we stop?
Do we
When
need to
did the
repeat
sound?
anything?
Yeah, when did the sound go off?
I think it was
Okay.
only frozen.
Oh.
Okay.
Okay, so where are we at? The healthy individuals? Yes. So these ones, they need to, or the GPs need to make sure they go for the screening to make sure that any conditions that might be emerging are picked up early so that they can be treated, and then also that these individuals remain healthy and then they don't develop any conditions. So as you see, primary care physicians play an important part in managing the health of the population and keeping individuals out of hospital. And so to manage the admission rate into hospital, these providers are very important. Okay, so let's go then to the last section of this, or bit of this presentation, which is the proposed capitation model for Singapore. Okay, and we are, as Tiwa also mentioned, we have limited information, and we are eagerly awaiting the details that will be shared later in the white paper later this year. But what we know so far is that the funding model will be changing to capitation. in that each of the 3 health clusters will receive payment per member of the population attributed to them. How they will be allocating these funds between hospital care and primary care physicians that need to help manage the admission rates, that's not clear. But we know why this model is being implemented is to better manage the health of the population and hence manage the risk of escalating cost. How this will be managed will be through tracking the specific health outcomes and therefore ensuring that the incentives of capitation is aligned to the better management of health as its purpose. Okay, so let's start the discussion part then. That's enough of me talking. I'll be asking our panelists questions.
Here's a question already from the audience.
Okay, great.
Maybe you want to take that first.
Okay, so this is a question to me.
Yeah.
And Tim.
Is there any literature supporting the statement? Tim is helping. Tim, do you want to answer? Maybe save you some typing.
I was typing and I was thinking, I don't know if I want to say this one. Look, I think more test services being good to the health outcome or not good to the health outcome. I have heard it said, and commentators do occasionally say, you know, extra procedures can be not good to the health outcome. I'd say that's rarer, and you know, some people may still disagree with that. Generally speaking, the medical profession does have as a value to at least do no harm to the patient. I'd say it's more common that you have additional tests that at least offer no additional benefit, which I think is almost equally as bad, where you're just generating financial incentive, providing extra tests that at best aren't leaving the patient any better, but yeah, at worst could be actually making a detriment to the patient's overall health. One example I did think of is obviously palliative care. It's a politically sensitive issue, but the research does show that some of the highest costs incurred are in the last stages of life. There's often a lot of very intense acute procedures, investigations, resuscitations that some would say are unnecessary. Others might say they're cruel. Certainly at that stage, they don't offer a lot of utility to some patients, and that's where you know, that's one example. Another example in a different field might be successive IVF rounds of therapy beyond a certain point. There can be real and significant risks of overstimulation, which can be quite dangerous in some circumstances. I know some countries, particularly GCC countries, where culturally, you know, it's very, very important to have many babies and as young as you can. Disturbingly, will put quite young women through quite a number of rounds of IVF, which is arguably not doing them any benefit and putting them at some unacceptable risks, at least viewed by others in the world. So they were just some examples that came to mind.
Yeah. Maybe I would actually add to that. Even I think we have fairly good evidence that, you know, the practice of defensive medicine sometimes really does go very far, and that for patients, particularly when we have too many tests that actually have very little prognostic value, at the end of the day, sometimes and when we have too much information, people are subject to false positives, and they don't really know how to interpret that information. I think we also have detrimental effects on the patient experience and patient well-being at the end of the day. So I would say, you know, we do think about those clinical outcomes, but actually for patient experience also, it is the case that more services and tests are not always the right thing to do.
Thanks both. Thanks for answering my question. It's very good having a panel to help. Okay, so let's go to the first question in our panel discussion then. So what we wanted to learn from our panelists today is, first of all, you know, what have been some of the learnings that we've had from international experience where capitation models have been implemented? And specifically, you know, what's worked well in those markets, and what would be some of the pitfalls to avoid? Tim, would you want to go first on this one?
Sure. What I can say is, at least in the US markets and in some of the GCC markets that have, well, as well, Australia has explored the issue of capitation. What we know is capitation doesn't work as well for all services equally. There's some services it's much better for, and some that it's, you really wouldn't want to consider it. And generally, some of the things we look for is good homogeneous care pathways, good standardized clinical practices, things like knee replacements. Some say maybe even prenatal and postnatal care for maternity. That could be something that could be bundled. Our Independent Hospital Pricing Authority in Australia has released, as part of its pricing framework, some work they've done to look at the procedures we have in Australia and those which would be conducive to bundling or capitation. And I must say, they found that in a lot of cases, a lot of our procedures currently are probably not amenable to that. And I think Lydia touched on it earlier that you do have a natural incentive for the provider to reduce service provision, and that brings quality concerns. So one of the lessons obviously learned overseas in the, again, US and GCC, is when you implement capitation, best to also have minimum quality standards and also potentially performance incentives for baseline levels of service provision, so that you don't end up with providers just opting not to offer services and generating poor health outcomes.
Thanks, Tim. Joanne, anything to add?
No, I think I would just stand by everything that Tim has said. I would just add also that some of the pitfalls we've seen in other countries with capitation is opportunities to cherry pick and really become very driven by those types of financial incentives to make sure that at the end of the day, the provider does not, quote unquote, lose out. And my sense is also that, one of the things I think that we have seen is that capitation is a whole health system intervention. And we introduce financing, but that's not a magic bullet. What we need to see is that there are savings that can be on the extensive and intensive margin realized, that we do have options to move to for more cost-effective therapies and pathways, and that at the end of the day, we have very reliable strategies for preventive care to actually work. And so if we don't have the care models and capacity to carry those out, financing alone is not going to make that difference, or rather at the end of the day, what we're going to see is those degradation of quality that unfortunately we will not be incentivized to do. I think the other thing just to also mention is that one of the pitfalls, I think, is that we assume or we hope that capitation models have a beautiful simplicity in theory, but I think we've also alluded to in both the presentation and in Tim's remarks, the fact that in fact it's a complex beast. We need the right data. We need to be able to understand and execute on risk management strategies at very many levels. And we need to have the health system's governance to make that work well. And so it's not a win-win proposition immediately. And it's actually very much that the devil is in the details as well, in both the planning, I think, and the execution.
Thanks. Yes, so as Joanne mentioned, all of those things need to work together. And TY also presented earlier with the healthier SG. Capitation is just the funding model. There's the GP activation. There's the the quality care measurements and all of those things. Tim, if I can ask you practically, what do you think are some of the key considerations in moving forward? In terms of technology and GP. What practically how do you go about this? Where do you start?
Sorry, Lydia, just to clarify on that, you mean to maintain data capture and to make it actually work in practice?
Yes.
Yeah, well, I think we need system. It's a lot like the care models themselves. You need a great deal of integration. You need systems interoperability. You need clear data transfers and hands-offs. In those markets that I've seen implementing new health system schemes, whether it's capitated models or other models, most require at the core a health information exchange, whereby certainly the government, the primary funders get access to all the information from a trusted central repository to monitor, adjust pricing, reflect on the experience, so that you're not in a situation where you're reliant on reporting from providers. That can be a key risk area to kind of avoid in the case where you're almost outsourcing your data and information feed. Obviously, providers may be incentivized not to give you accurate or complete information. So it is a common consideration to have an integrated, centralized health exchange that can collate all the information, and things like national integrated electronic health records are critical and a key part of that too.
Thanks, Tim. And then, Joanne, maybe if I can ask you, so let's get back to my question. How do we, if say everything has been set up exactly, like Tim mentioned, it's the best case scenario, how do we measure the success of capitation then? Because, in a preventative care, cost will go up initially. And so how do we actually measure that capitation actually drove the services to preventative care, and then that preventative care actually managed to make people healthier?
Right. Well, there's two answers to that. One is with the data that we have in the public domain, it's going to be very difficult. But in actual fact, I think that both of those elements that you mentioned are really important. One is to basically have at some level measures that really get at the ratios of utilization and to understand whether or not we are banging into capacity constraints, and whether or not we are seeing, for example, things like our waiting times go up that suggest care rationing is happening. And then to have those population health indicators that we want to see at the very disaggregated population level to try to understand what happens. But I think a very key ingredient, as you mentioned, there is time. Capitation is not a silver bullet that's going to happen immediately. When we look at first of all, the stratification into these different groups, the risk management benefits that we get at the very top of that pyramid will still take some time to kick in. And when we look at the healthier SG population, which is the 40 plus going through the screening, those benefits we're not going to see for 5 years or even 10 years. And so at the end of the day, understanding whether capitation worked or did not work from a process point of view is what we're going to have to track very closely in the first few years. And then to be very reasonable, I think we should not expect those health outcomes to transform in anything shorter than a 3 to 5 year period, even at the beginning for the proxy outcomes. So time is an important part of this equation.
Thanks, Joanne. I will go to the Q&A now, which kind of links to how has the public been impacted, which is the next question. And there's one question around, would patient choice be compromised for the capitation model, especially in cases where particular treatment might be 50-50, beneficially for the patient? The healthcare provider would have an incentive to reduce the service. Any suggestions, Tim, on how to manage this unintended incentive?
Look, it's a really good question. I think there's always the option that a patient can pay privately. So patient choice isn't completely eroded, but certainly it's hard when there's no financial subsidization. Voucher-based systems can be used to put the choice in the hand of the patient instead of the provider, or using, for example, health savings accounts to subsidize some of those choices of the patient. So I think there'd be ways that it can integrate within the existing system that doesn't completely take away patient choice, or at least helps to mitigate some of that regard. But yeah, it is a feature of capitation that obviously the provider will be inclined to recommend the cheaper service, and without the right quality controls, that may not necessarily be the most effective service or the one that has the best chance of the long-term sustainable outcome. Capitation done really well with the right controls and the right things in place to measure and monitor quality and safety, and holding providers to account over a longer period of time with a fixed payment. Providers do have to think about giving the most sustainable, prosthesis, for example, rather than one that's known to be not particularly good. So there are ways to do it, but it needs a number of considerations and controls, I think, to make sure that patient choice is supported and not eroded.
Yeah, and of course, that's some of the detail that we're waiting for in the white paper as well, to understand, how those cases would work and what options the population would have outside of these options. So another Q&A question, maybe Joanne, can I ask this to you? Some believe that capitation model in principle is to improve health outcomes, but in reality is to reduce administrative and billing costs of medical practitioners. In addition, doctors have incentive to increase enrollment to increase profits, but reduce attention to each patient, leading to poor health management outcomes. Do you agree with this?
So I'll take that in backwards. I think it's certainly the case that they do have the incentive to do this. I mean, the incentive exists, but I think as Tim has mentioned, the idea then is to build a system that contains that incentive and counteracts it with other quality-based incentives. Of course, to understand that the drive, that while the potential is there, that I think our experiences in this area, by putting the right data in place, we can mitigate that risk. But I think not to acknowledge that risk would be, I think, really, disingenuous and to sort of be denying of the reality of the model itself. And so I think being very pragmatic about what that does introduce allows us to plan ahead for these issues. And so a very clear recognition that that is in place is what drives, I think, putting all of these quality and performance measures in the first place. I think the first part of this question, that in practice, again, this is one of those things where it seems that capitation models would make billing and administration very simple. But in practice, when we introduce capitation, very often it's a mixed bag. We have capitation for certain things, we have fee for service for other things. And at the end of the day, sometimes it can actually make things a little bit more complicated because we have different bundles of services that are under the capitation model and others as well. So in practice, I think the reality is that sometimes capitation makes administration and billing easier, but sometimes it really does quite the opposite. I think that's something that we have to watch as this rolls out as well. And so again, I think the details are going to be very important.
Okay, and then sticking with the international experience first, there's one question on Q&A on some international country examples. Or Tim, do you know of any international country examples with successful cost savings from capitation?
Yes, the United Kingdom. So the Commonwealth Fund is a pretty reputable source for ranking international health systems on a range of different dimensions. Of course, the beauty of that is each country can find a dimension it does really well at and brag about that. But the United Kingdom is probably right up the top in terms of its cost efficiency. But I think on some other measures, for example, the outcomes themselves, it isn't as great. So you'll see some of those key differences. Yes, certainly there's evidence of savings, but is there evidence of over the odds value or quality? That's a bigger question mark.
Yeah, and I guess that's also the case then with, because, they're doing very well in efficiency, but then you always get this, the NHS is very expensive and the costs are still going up. So it's again, like, as I mentioned, I guess, to what extent do you measure success? Because costs are always going to rise. What would it have been had you not implemented capitation?
Exactly, and what we find here in Australia as well is we've got a big focus, as most places do, on value-based care, and it perhaps seems obvious to most, but better value care as measured by really good patient experience, as well as good health outcomes. It's more expensive and it's not necessarily cheaper. So, if you're meeting increasing community expectations for what care involves and how it's delivered and what the hospital looks like and what kind of level of technology is in the hospital, capitation is not always going to be a road to cheaper care.
So over here, I'd just like to jump in and answer one question. There's quite a good question on the Q&A. Given the change in financing model, how does the panel imagine the role of insurance in supporting the financing, be it for public patients or private patients? And how should this differ for group employee benefits and shield insurance? So I think in the short term, in the next 1, 2 years, 3 years, realistically speaking, you wouldn't see any change as yet, because the bulk of the change is in the way the government is funding the public healthcare system. Today, it is what they call a subvention, a DRG, and in relation to numbers, it's like close to $5 billion. So in the short term, 1 year, 2 years, 3 years, realistically speaking, I don't see any significant change in inpatient side. MediShield Life will still remain MediShield Life. Group employee benefits will still remain group employee benefits. That being said, my own personal opinion is that given healthier SG on outpatient and the increase in subsidies, each person enrolled into healthier SG effectively has a easily accessible clinic that will charge him something like a polyclinic price. The total price for his chronic medication may be $100, $120, but the net amount that he pays out potentially maybe $30, $40. So on the employee benefit side, there may be some impact or some change in simple terms, imagining that there will be significantly more government polyclinic claims or more subsidized claims. Joanne, do you have any comments that you can share?
No, I think I would defer, I think, to what you said. My sense is that actually that's actually right. I would expect that to be there to be actually phenomenal changes right away. But again, I think it comes back to the remark about the fact that it's going to take time for us to see these effects percolate through, no matter what happens.
Okay, so let's move on to the next panel topic. We'll come back later to general Q&A, so please still keep sending your questions through, but we'll just make sure that we cover all our questions and then the general Q&A a little bit later as well. For the next section of the discussion, what we wanted to talk about was a bit more technical in terms of calculating capitation rates and suitably accounting for the risk in those calculations. So maybe I'll ask Tim, as health actuary, how would you go about calculating capitation rates for beneficiaries?
Yeah, look, this is a good question. It certainly just depends on the maturity of the market you're working in, but like most things, you start with historical experience. So what is the current utilization by different segments of customers for different procedure types, and baking that in to your initial capitation amount, allowing for a level of variation to give yourself some confidence that a certain level of service provision you want will be delivered in the market. Of course, like all good actuaries, we need a control cycle around that. So you absolutely need to review, particularly when you're first starting, that a couple of times through the way to make sure you can readjust to deal with unintended consequences that may come out, or behaviors that you didn't necessarily anticipate that start to emerge, or different care patterns that emerge due to the discussion we were having earlier. That was one of the major failings that I saw while helping one of the GCC countries implement their new health insurance scheme with a capitated model, is that the big reason why it fell down was just the costing and the pricing initially was so far off what it needed to be. So in short, based on previous experience, or if you don't have previous experience, based on benchmarks from other similar countries, but they do need to be revisited and reviewed.
And then maybe, Joanne, if I can ask you from the risk side and maybe from the provider side, if it's this negotiation taking place between funder and provider, how does the provider view their risk and the capitation rates they're going to receive? What can they do?
Right. I mean, fundamentally, especially when we're going from a fee-for-service basically to capitation, that's a very radical change for a provider. I mean, and fundamentally, again, I think one of the things that we discuss here in this forum is that the need for an actuary to step in here and really give that experience to the provider is something that in the past, right, within our healthcare system, just speaking about Singapore, has not been, the need has not been there in the same way that we face with capitation now. So my sense is that in these discussions, these are all new ways of negotiation and discussion. We're bringing new types of data and new types of conversations between providers, funders, and this is something that I think that providers here are very nervous about. And this is an entirely new space for them to be speaking about, and that this language around actuarial risk is something that actually professional support around these concepts, these negotiations, trying to understand the margins for which they can negotiate, are all new conversations, and we need to enter them transparently and openly. And again, for that reason, I think a lot of data needs to be made more transparent than it is now. And also mindsets need to change.
Thanks. And then also maybe if we go a bit more technical, Tim, and we just think about each beneficiary and how you would actually account for their risk. So what are the factors that you would typically use? Do you use age and gender, chronicity, or what would you look at as risk adjustment?
Yeah, certainly. So you often will look at comorbidity index, things like the Charleston score. You'll also look at potentially, depending on how sophisticated you are, social determinants of health, socioeconomic advantage, disadvantage, or depravity, as measured by region, depending where they are. You'd also look at BMI, for example. It depends on the legislation, what you are and are not allowed to use. Each country obviously has its different protocols and legislative requirements around pricing, particularly when it comes to health. But there's certainly the key risk factors, smoker, non-smoker is another example. It's all those key factors that we know as actuaries drive care usage and drive long-term poor health outcomes that would be factors you'd use in risk stratifying across the different kind of bandings of your capitated model.
And I think I saw on the Q&A, Joanne, as well, we received a question about, what about insurers? So we're seeing this capitation on in the public space. Do you think there's a chance that more insurers will now start to consider capitation? Or what could be the potential impact on insurance products? Or maybe TY, do you want to jump in as well?
The critical point about capitation is that it needs to be large enough for it to be manageable by the medical provider. So in a Singapore context, you are talking about 1.5 million residents per healthcare cluster, and each healthcare cluster, if you're not fully aware, there's one cluster centered around National University Hospital, NUH, in the western part. Then there's one cluster around SGH. You have kind of look at the map, it's a bit of kind of shape. Then there's another cluster around Tan Tock Seng Hospital, and each is about 1.5 million people, right? I think given those numbers, I suspect, and also because the Singapore context is in the inpatient side, 80% public, 20% private. So on the health insurers, private health insurer, nobody has so big a portfolio to negotiate with the public healthcare system. And the public healthcare system, my personal opinion, is unlikely to negotiate with anybody else outside of the government. On the private provider side, inpatient care is a bit too volatile for any one of them to absorb. On the outpatient care setting, yeah, there may be third-party administrators and whatnot taking some level of risk, for GP or specialty services, but that is not so big a number as compared to this shift in funding model to capitation for the public healthcare system. Yeah.
Just to add my personal view, I think for the insurance, Shield is in particularly covering only inpatient treatments for the private insurance, and EB covers inpatient plus outpatient. So one of the difference we expect from the capitation or from this whole healthier SG model is there would be more visits, because we are trying to move towards preventive care. There should be more screening and more visits to the GPs. So in reality, if people are becoming healthier, the inpatient claims should go down over time, and outpatient claims in the initial time period for 2 to 3 years will definitely go up. What it means is maybe, again, my personal view, but maybe for the outpatient care, the bill size or the visits would see an increase. but on the inpatient care, there should be a drop eventually in the mid to long term. That's what I think. Financially, that is how it should impact the two different product types.
Thanks, Betty. Okay, shall we go to the next section, and then we can loop around to Q&A afterwards, because I see there's still a lot of questions coming in, but I want to stay on topic. I've already drifted off topic a little bit. So let's do the next question first, which is what role do actuaries play in capitation models? So again, Tim, maybe you want to go first as the actuary.
I think the entire concept of capitation models is just one big home for actuaries, but economists can stay in the guest lodge house. But no, I mean we both equally do as well. There's a lot that actuaries can do. The risk transfer is essential. It's an essential concept of capitation. Particularly, we had the question earlier around should you look prospectively or retrospectively, and is there going to be risk equalization mechanisms if you're going to do something based on age, so that you're not you're dampening that impact on the higher ages by cross subsidizing with younger ages, and you need to be able to look forward and project what do you think your utilization is going to be going forward. You need your actuarial or economic models around what your average cost is going to be per service, and how the whole thing's going to emerge over the forward years to be able to have a decent stab at what should be your best estimate for the capitated payment. And I know Lydia was going through the slides earlier about the different funding models. This is one of the big challenges about capitation. It's actually easy on one hand, but on the other, it's incredibly complex. It's very difficult for providers to understand how we arrived at that payment that they're getting. They're always going to complain it's not enough, and then there's a lot of risk in that you get it wrong, and if you get it wrong, people don't get as many services as they should, and you get all other kind of problems creeping in. So I think it's very important that we have as many, I'm going to say, data and analytics orientated professionals as we can in the area of capitation, and making sure that we're thinking about the risk and the uncertainty and advising payers, providers, patients, all ends of the spectrum on how to make it work.
I could not agree more. I think at the end of the day, risk is what makes capitation work. And that's the fundamental engine of the model. And so as an economist, I'm sure you have a very nice guest house. very happy to sit there, and we can contribute something about steering people towards making sure incentives are set right, making sure that cost effectiveness and value-based care is part of this. But what makes capitation go is the risk piece of this, understanding it, pricing it, and making sure that those numbers are right. So the fund, I would say, it's not just a home for actuaries. I think this is the entire mandate. I think of it rests on actuarial science.
Okay, thanks, Sharon. Okay, so yeah, let's get back to general Q&A now. So any topic is up for grabs again. Let me start. Okay, so I'm going to refer then to the Q&A section in the Zoom call. So please add your questions there if you have any. Let's ask the first one. Maybe TY can help on this one. Is there any information about how the funding will be distributed to the multiple providers, for example, hospitals, GPs, and specialists, to understand what incentives each provider would have to keep patients healthy and out of hospital?
Okay, so working on publicly available information, my understanding in a Singapore context is the government hospitals and the government specialists are operating within the same system, right? And the other side, on the private GPs, you have the public, you have private GPs, right? On the hospital and specialist public side, yes, that funding is per member per year, 1.5 million people. The minister has assured the people that the budget is effectively higher than what it is this year. So whatever subvention amount they used to receive, my understanding is about $5 to $6 billion in total countrywide. They will receive a little bit more, but in the following year when this is implemented, it doesn't matter whether they do, 1,000 or 2,000 surgeries or 20,000 surgeries, the funding wouldn't change. Right? In relation to risk adjustments and whatever not, we don't have enough information on whether, for example, the Congo population, the government is paying less because that is younger, vis-a-vis the Red Hill population, which is older, and the government will pay more. Those information we don't have as yet. On the private GP side, the ministry has shared with in an open forum 2 doctors that it is largely unchanged from what they are today. And just to give a little bit more context to people, number one, you have your community health assist schemes, which has a fixed subsidy depending on what level you're at, or depending on pioneer generation, medical generation, means tested, and so on and so forth. At another level, there is already what you call a primary care network for each and every cluster, where they collaborate with different GPs within the area to send patients who have discharged or patients who need chronic care, don't need specialist care, for example, to the private GPs, and the government hospitals would pay what they call a care plus fee or something like that. I'm not aware of exactly what the numbers are, but it is some number, and the private GPs are reasonably happy with it, right? So on that basis, the conclusion is, on the private GP side, it will largely stay fee for service, and on the hospital and specialist side, there will be some impact, but it's a large 1.5 million people type of impact.
Great. Okay, great. Thanks, Tiwa. Joanne, you spoke a lot about, how can you measure, the quality and measure the outcomes of capitation to make sure that it actually works. So we have a question asking, what would the panelists regard as the key KPIs for monitoring performance under the capitation model?
From a population health management perspective, I think we would look at the kinds of things that we look at currently in the population. I think so all of our typical epidemiological indicators, as well as our use indicators. Obviously, I think we will still measure as far as we can the breakdown of costs across the different providers. But fundamentally, I think for the capitation model, as we roll them out, actually keeping those health indicators front and center are going to be very important for us.
Thanks. Tiwa,
Okay. So there is a comment around is healthcare capitation payments and management of such funds appear to be another form of Medishield integrated shield. In our view, how do we foresee the management of such fund in relation to Medishield, employee benefits, and integrated shield plans? Actually, I don't believe there is an impact in the short term, because we are talking about the government grants and the government subsidies that have been paid into the hospital, the regional health systems already. As a member of a public, you see that number in relation to, if you have ever been unfortunately hospitalized, you would see that if you go to a B2 or a C class ward, your cataract surgery, for example, will start at $12,000, then they will give a $7,000, $8,000 subsidy, and the net amount that you have to pay is only $3,000, $4,000. And thereafter, Medishield Life and Integrated Shield, all these things will kick in and pay off those amounts. So, yeah, I don't think there is a short-term impact. It is more in relation to the medical provider side, especially the regional health systems.
Thanks. Maybe Tim, I see one question around, under the current financing system, consumer price signals are one of the fundamental protective principles. Will this be retained in any form under the capitation approach? You maybe discuss also some of those key issues, of data lost and, unit costs. How do funders actually, monitor the price of services, or maybe co-payments, or out-of-pocket payments that beneficiaries might still be liable for.
Yeah, look, it's a very good point, and I think it's interrelated to one of the earlier comments I was making about the requirement for a good health information exchange and a good centralized place for data on not only patient activity, but also you want data on cost to deliver the care. So here in the Australian market, we have, as I mentioned earlier, the Independent Hospital Pricing Authority that's responsible for setting the national efficient price for healthcare. Now, to do that, they require a submission from each of the hospitals all throughout Australia around what the average cost is against every kind of procedure, and with a whole bunch of characteristics around the care that was provided attached to that. And that's been happening over a number of years here, and every year the data collection's been getting better and better in quality, and the standards that are to be applied in costing hospital services have been improving and improving. And so just because you're changing your reimbursement model, for example, from a fee-for-service schedule to a, whether it's a bundled payment by DRG or to a capitated payment per beneficiary, doesn't necessarily mean that you're going to change your requirements in terms of cost data and what you capture from the system. I mean, I think you have to continue to understand what those costs are, precisely for the reason that you're going to need to go through the process of setting your capitated amounts again. So if you've got private health insurers, they may not necessarily be reimbursing their providers that are giving you the care under a capitated model. It's just that they're provided or they're funded by the government in a capitated manner. So they've got to be the intermediary that works within that capitated envelope, and they need to manage their contracts and understand the costs of their different providers and the mix of different services they may provide to you, so that it fits within that bundle and achieves everything it needs to achieve. So there's the two sides, and I don't think you definitely can't do away with information in terms of cost, so that you can measure how that cost is increasing, and in what areas and for what kind of services. You do need that data.
Thanks, Tim. Okay, so going back to Q&A again, Joanne, maybe can you help with this one? Do you mind sharing again what's the difference between the capitation model and the current model? And the question is specifically about from the consumer standpoint. If I were to go to the hospital, go see a GP, what's the difference now to me about these two models? How's it impacting me?
Yeah, so I think TY also had mentioned, right, what the consumer will see in terms of their hospital bill. So at the end of the day, right, the way that we would see this would really come through the change in those subvention numbers. And actually, I don't really know how this would be presented from the consumer perspective. That's something that's still very open to us. But fundamentally, the difference, just to reiterate again, would be that currently reimbursement on a fee-for-service basis means that per service that you experience or that you're given, basically reimbursement proceeds on that service-by-service basis. And under a capitation model, what happens now is that reimbursement will proceed on a per person, per period basis. And so we're going to go from a payment that basically fluctuates based on the amount of service that's captured, that's delivered, to a single fixed payment. Again, this could be defined in scope for different bundles of services and different things like that. But we're going from something that is per service to per person. And that's the fundamental difference actually in the delivery of the capitation versus the current model.
So I'd just like to add on that is for private GPs, not much change. Private specialists, private inpatient, I don't believe there's any change. Public inpatient, public specialists, potentially, public specialists, I also don't believe you will see much change, granted that a lot of it is non-subsidized or the subsidy is not obvious, kind of thing. The public inpatient will probably be the largest change, but genuinely, we don't have enough details on how it will impact. That's also one of the main purposes of this one.
Yeah, no, that's exactly right. I would say that right now, all we know is that the clusters will receive that capitation payment, And those are the things that will change on the what we actually do not know for the other parts of Healthier SG, if together with an empanelment, if there are going to be other ways that we'll see that change happen. So at the moment, it's very difficult for us to say what the consumer experience will look like just from the information that reimbursement at the cluster level is going to flow down in this way.
Thanks. So Tim, another question for you. Will capitation result in further inequity with the more wealthy choosing private cover if the capitation is now in the public space, hence driving up the cost of the private care and negatively impacting insurance? How can we change the mindset of consumers that more is not always better?
Yeah, it's a challenging question. One assumes that consumers are rational in any market, but time and time again we see that that's not proven to be true. And I think it was mentioned earlier in the presentation that there is a great deal of information asymmetry, and in the doctor-patient relationship, quite often the patient is just simply trusting in the doctor. So I think the best thing we can do is to promote transparency, reporting on the outcome rates of procedures, those that are more successful, those that are less successful. Because if you have a proper financial disclosure discussion with your patient, and you were to put in front of them, I can do this procedure with you. You'll only need to do it once, and you won't need to see me ever again, and it costs you X. Or you can do this other procedure, and I can tell you right now that 90% chance you're going to be back here once or more in the next 3 years to get this adjusted or even completely removed. I mean, who would choose that option? So part of the problem must be that we just don't have that kind of information in a place that consumers can access and understand. We're not promoting that kind of dialogue. I think that's a big part of improving and empowering the consumers to drive those discussions.
Maybe if I also want to pick up on that, sometimes it's also very difficult for us to convince providers of this as well. And we do have our, ACE, our Affordable Care Agency, and we put out appropriate care guidelines, and we try to engage with providers around those as well. And that's also an equally difficult conversation. So it's not simply just, consumers, but actually the provider side of this is also part of the conversation that's been challenging.
Okay, so I think we've got time for one or maybe two more questions. So the first one I want to ask for Joanne, in terms of, the population health management you spoke about, how do you view the relative importance of wearables or other new health tech in tracking and achieving preventative health outcomes? Would providers go in the direction of encouraging positive lifestyle habits in place of HPV?
But I think the great hope is that now we've aligned providers with what HPB has tried to do, and we do know that I think in line with the theme that you had brought up at the beginning, that digitalization, tracking, and lifestyle change at the individual level is a movement in Singapore that we've been building up to for years and years and years, and putting different part of that infrastructure in. So we would hope that that works. I mean, we know that HPB has also been very active in looking at all of these new technologies. I would say that it's not as simple as it seems, and that there's a lot of data that we're getting from different apps, different sources, where interoperability is an issue for some of these things. So sometimes I think there's a great promise from this landscape and that kind of data, but again, the devil is really in the details. And sometimes I think we're very optimistic about these new personalized technologies, and my sense is that that promise has yet to be fully actualized, but hope springs eternal.
Thanks. Again, one last one for Tim quickly. Risk equalization will be tricky in the context of capitation funding of health clusters as the population they serve are fluid. People can move from one area to another. They can seek treatment from different hospitals. How do you manage this in a capitation? How do you attribute patients and make sure they go to the right providers?
Yeah, look, excellent question. Very quick answer. Patients are obviously enrolled to the region, and it's quite easy. You just remove the level of subsidy, or you charge an excessive fee for out-of-area services.
Yeah.
That's simple as that. Risks and controls.
Thanks, Tim. Yeah, and that concludes the panel session. Thanks very much, Tim and Joanne, for sharing all the knowledge with us. Back to you, TY.
Yeah. Okay. So just before we close, a few last comments. Yeah. We have a Zoom poll. As a follow-up, please.
We didn't fall off the table. The camera fell off the table. just so that in case anyone is concerned.
While you all are answering the poll, just want to apologize for not being able to answer everyone's questions. But at the same time, do note that we are collating all these questions, and within the committee itself, we also have some questions around this whole Healthy SG. We do intend to collate a list of questions and share it and engage the Ministry of Health as the Singapore Actuarial Society. So thank you very much for your attendance, and thank you very much for your questions.
Thank you. Is it?
I
Maybe
think
we
they're
still
still
have 1
answering.
minute.
Yeah, still have 1 minute.
Maybe I want to thank the panelists and the speakers. So thank you. Thanks to all the speakers. Thanks to the speakers and the panelists. I know a lot of work has gone behind it to put it together in such a short time. And thanks specifically to TY and Lydia for putting this together. And thanks to Dr. Joanne and Tim for joining us in the panel discussion today, which was very interesting. I personally thoroughly enjoyed it. For all the audience who were sending their questions, the questions were really very insightful and very helpful to drive the discussions. So thank you for joining in today. And thank you, special thanks to Tim for joining from Australia. And I would also like to thank SAS Secretariat to support us in this, and also rest of the team members who are sitting here, without whom we would have not been able to manage it and put it together. So thanks everyone. It was a nice discussion. Bye-bye.
Thanks all.